Hi everyone, my name's Rachel Moses and you are listening to an ACPRC podcast on pulmonary rehab. And pulmonary rehab in this digital virtual world we're now living in. So I'm delighted to announce the panel joining me today. So we'll start with Esther. If you could just tell us where you are, where you're from.
My name's Esther Mitchell. I'm the operational lead for the respiratory service at Gloucestershire Health and Care NHS Trust, and I'm the clinical lead for the pulmonary rehab service.
Thank you. Elaine? Oh, I'll unmute you. Elaine, I've unmuted you, Elaine.
Okay, hi, I'm Elaine Bevan-Smith. I'm a lecturer at Gloucestershire University. I've had many years' experience delivering pulmonary rehab, and I deliver a physical activity model of pulmonary rehab called Breathe Happy.
Yes, and that's how we would best know you. Breathe Happy on Twitter. Sam?
Hi, I'm Sam Pilseth. I'm a physio consultant working in Knowsley on the outskirts of Liverpool, and I help run a pulmonary rehab service, and I'm involved in the Cheshire Merseyside respiratory improvement plan, which includes pulmonary rehab.
Fab. And Paul?
Hi, I'm Paul. I'm from Birmingham. I work at St Mary's Hospice on the Space to Breathe clinic, dealing with people with chronic breathlessness, and also co-founded Pulmonary Rehabilitation Week with Elaine, the wonderful Breathe Happy.
Thank you. So we're putting on this podcast and it is a little bit short notice, so I'm really grateful to all the panel members. And the reason it's a bit short notice is it's Pulmonary Rehab Week number 1, we know that, but number 2, people have been struggling for some time now on actually how to start that pulmonary rehab online, and we've seen lots of pockets across the country of people doing that on a one-to-one individual basis, and outpatient activity. But what a lot of services are telling us is that they're really struggling to implement a virtual PR program. So this is just people's opinion. Everyone on this podcast it's their opinion. It's not the only way, it's not the best way. They're just brave enough to come on and talk to us and share their ideas and experience. So being a non-PR expert, I just want to know, where is the challenge? So we know PR is effective. It's hugely evidence-based. It's hugely cost-effective. And we have set outcomes. We have ways of doing it. We have pathways, and it's been running for years. So why can't we just pick that up and do that virtually? What are the risks? What's the stop and gap? What are the dangers of just doing that? Can I come to you first, Esther, to try and answer that?
I think you could turn that question around as well to say what are the risks of not doing it. But I think in terms of risks, a lot of, I think as therapists, we are conditioned to measure our services. We have to benchmark against other services. I think that moving from a face-to-face model for a virtual model brings challenges in terms of services potentially proving their worth, because we can't use our validated walk test measures. We have to potentially...
Oh, I think we've lost Esther. So Sam, can I come over to you to finish that off? I'm not sure where Esther's gone.
Yeah, I would argue that actually we don't do pulmonary rehab very well. If you look at the recent audit data, 15% of eligible patients are offered pulmonary rehab. I don't think that shows that we're doing standard pulmonary rehab very well. So I think even if we weren't in this pandemic, we need to be doing things differently in rehab anyway. What we've done for years and years and years is evidence-based, but I'm not sure how well that works with our patients today. I know locally we have massive problems with picking up standard PR and putting it virtually. Part of that is because I work in a very socially deprived area where patients don't have access to internet. So that is a huge stumbling block to our patients going online and engaging in sort of virtual classes. They physically don't have the ability to do that. Risk-wise, as physios, we like to thoroughly assess our patients, and that's a challenge to do that virtually, because you don't know how they're going to respond when you exercise somebody with chronic respiratory disease and complex comorbidities. So we have to be quite creative on how we do that. We do a lot of our thing online now, or well, on telephone, so we'll have a telephone assessment with patients, and then we are going out and visiting patients and doing a face-to-face, so we can do an exercise test with them, because we need to know how they respond to exercise, because if we don't do that, you know, as therapists, how can we set an appropriate exercise plan for them? So we are doing a lot more home visits for this patient group.
Absolutely.
So we're also having to risk assess the environment, because if we're getting them to exercise in their own home, is that suitable? So we're advising patients on clearing spaces, you know, making sure they've got people in the house when they're exercising, and they've got access to telephones, they've got water, they've got all their, you know, all the medications that they might need to take, and we have that as constant prompts. We've been setting target SATs and heart rates for patients, and if they're doing any exercise and it's going out of their target range, we're asking them to stop and contact the service. And we've also been investigating the sort of disposable blood pressure cuffs, because at the minute we haven't got any way of sort of, you know, taking patients' blood pressure pre and post exercise. So I think the idea is it will, you know, leave those cuffs in the patient's home. When sort of COVID did strike, we put a mass order of SATs probes in that we're actually signing out to the patients, so they've got some way of monitoring their own exercise activity in the home while, you know, whilst they're doing programs that we set.
So you've kind of jumped onto one of my points, which
Sorry.
no, you're just too good. You know what I'm going to ask. Go ahead. But one thing we've known from some of the other podcasts, especially when we've done the community one, is there's pockets of community, integrated community respiratory services that have never stopped. There's some that have stopped completely. So the kind of the differences across the UK are actually quite significant. What I want to slightly go back to is, I know, so we've been told that some pulmonary rehab services have 3, 4, 5, sometimes 600 new patient PR assessments waiting. So these are the services that already had a couple of hundred waiting, that would put on, say, 20 classes a week. So, Paul, if I can come to you and say, what is the problem with these patients not exercising? These are patients with chronic respiratory disease, you know, they're at home. A lot of these patients shield naturally, don't they? What's the problem? Let's just keep them at home, keep them safe, no exercise. What's the risk?
The risk is there's so many risks. They find it more difficult to get out of bed without exercising. They find it more difficult to walk across to the bathroom. They find it more difficult to without being too graphic, to get up off the toilet. They find it more difficult to wash their hair, brush their teeth, get dressed, have a shower. They find it more difficult to walk downstairs, up the stairs, more difficult to lift up a kettle. So all the things that they could be doing that would make it easier or better with exercise become more difficult. And as a result of them not exercising, their breathlessness starts to increase. Then they start to think to themselves, my lungs are getting worse because I'm getting more breathless, but it's a physical deconditioning. They then might be more likely to maybe call an ambulance because their breathlessness might be provoked by the anxiety. So then that puts a pressure on the ambulances coming out. They might be admitted to hospital. That puts more pressure on the NHS, who's trying to get patients out of the actual hospital. So through the one fact that they're not exercising, it starts to escalate and escalate and escalate. And especially their mental and emotional well-being, when they get more and more breathless because of the physical weakness, that can cause another cascade of problem. They're ringing their GP, they want to put on extra medication, their medications have to be adapted. So it's literally a tsunami of problems when they don't exercise.
So it's a minefield, it's a physical minefield. And I think everything you've said, and just the sheer, you know, mental health benefits and the, you know, that psychological achievement and everything that means to a patient. And that kind of brings us on to Elaine. And the Breathe Happy focus. So you have been doing a variety of online exercise, not necessarily pulmonary rehabilitation per se, but do you want to talk to us a little bit about, from the very start of this pandemic, how you've been using a virtual platform to keep your patients active?
Well, I think, and this is my viewpoint, as you said at the beginning, we all know that exercise, highly evidenced for people with respiratory disease. That's just absolutely without a shadow of a doubt. But I think what's not well researched, and what's very, very important in this sort of scenario, is that pulmonary rehab is not just about exercise. It's about being connected. It's about the compassionate relationship between the therapist and the patient. It's about the group dynamics. And that part of pulmonary rehab is very, very poorly evidenced. But we know, and I think it's a no-brainer, that it's clearly one of a key component within pulmonary rehab. Now, Breathe Happy is a physical activity driven model of pulmonary rehabilitation, and patients tell me equally that it changes their lives, just like they used to when I used to run Worcestershire Pulmonary Rehab. So it's for patients who don't attend pulmonary rehab, who don't want to exercise, who are exercise averse, who drop out, etc. But in a strange way, going online, it's actually much, much easier to deliver a physical activity driven model of pulmonary rehab, because obviously the safety issues are sort of a little bit more mitigated for. So you can actually just talk about physical activity per se, and I tend to talk about it, discuss it with the patients as in reducing sedentary behaviour. So it's not about, I want you to do these exercises, go and do some squats, go and walk around the living room 12 times. It's about just sit less, move more. Very, very simple. But what I've been doing Tai Chi movements for well-being, which is very suitable for people with COPD and other chronic lung diseases. And that's brilliant because the patients don't actually have to, it's very, very safe. They don't move particularly, they stand in the same position, just doing very, very gentle, very simple movements. And in the Breathe Happy groups that we've been doing, we have a lot of discussion. The patients seem to really relish just connecting with a healthcare professional, talking, asking questions. And the maximum exercise that we might do, fine line, I suppose, between exercise and activity. We might do a few squats, we'll do some posture work. We don't do anything particularly vigorous, but even so, they feel that it's good, that it's helping them.
Yeah, so you've kind of moved on to my next point and answered it answered it lovely in terms of what do patients want. So Paul, can I come to you? And I know you've been doing a lot of work with what patients actually want. What do they want to exercise during this pandemic? Do they want virtual classes? What's the score?
They definitely do want to exercise because they see the benefits. Say, for example, if a patient's away from exercise for maybe a month or a couple of weeks, when they come back to it, they often then notice a massive difference of how difficult normal everyday activities are. Therefore, they're quite keen to get back to it. Some patients might be exercising in the garden, walking around the garden. Some people might exercise. Some patients, they tell you, oh, we've been going online, been doing these videos. There's no safety net whatsoever in the videos they're doing online, but they've just been doing it. And again, the fascination is, well, they've had no problems they found a video online on YouTube. They've just started it, they haven't had any problems. Now, we've got wonderful videos such as the one produced by the the British Lung Foundation, the one that Julia Butt's on. There's exercise handbooks. So I've emailed patients the British Lung Foundation exercise handbook. There's the video that the respiratory physios produced that Julia Butt is on. That's now on, I think it's some on the online platforms, been emailing patients that, so they've been doing something to keep themselves active. They're desperate to keep active and they want to keep exercising because they notice they start to go in reverse physically when they get physically weaker. So they're very keen to keep active, but sometimes it's just about finding different ways to actually achieve this. But sometimes what we can actually do is, instead of us coming up with ideas and solutions, ask the patients, because often they'll come up with a solution, you think, oh, and they've thought of that, and there's your solution.
Mm-hmm. And Elaine, when we were chatting pre-podcast, you used the Joe Wicks analogy, didn't you? And so do you want to just explain a little bit about that? And in my head, I would think, well, that's okay, but actually these patients are sick, aren't they? These patients, you know.
Well, I don't know if Elaine mentioned this, but one of the things about Joe Wicks and other people like that, as good as what they do, there's no screening process, because we're legitimately, and for the patient's safety, we're very tight on our screening process. But I'm just thinking to myself, if they can do something independently without any input, advice or support from us and don't have any problem, that should be telling us something. And I'm just thinking to myself also as well, while other people are speaking, about an airline pilot. Now, an airline pilot, the more experience he has an extensive checklist. So what you'll find with pulmonary and cardiac rehabilitation, especially with respiratory patients who have heart failure on top of their respiratory, all you just have is a longer checklist before they start, and then they're off, because the most dangerous thing is not to exercise respiratory patients when they're stable. Mm-hmm. That's the biggest danger.
So Elaine, how do you get around that?
I think it was quite easy for me because I knew all the patients were originally coming to Breathe Happy in a group environment where I'd assess them all, and then we just went online. But I was sort of thinking, because when I provide the Tai Chi, I haven't assessed them. So a couple of the moves, they have to bend down, and they could have Meniere's disease. They could have postural hypertension. I don't know that, because I've had a couple of patients from America join. And I just have to talk about the basic principles of exercise safety. So if you have a predisposing musculoskeletal problem, then obviously you use your soft limits, so you wouldn't do anything that hurts. If you get giddy, if you feel instinctively that something's not right, then you stop. So there's some basic exercise safety principles that we all know. We lecture patients about it during pulmonary rehab, and in pulmonary rehab the minimum is 2 supervised sessions and 1 unsupervised. Well, we don't sort of supervise them in that 3rd session, so how do we know that they're exercising as prescribed? I think sorry, carry on.
No, that's really helpful. So I think we've clearly identified now that exercise needs to happen, and we need to modify the way we deliver exercise in this digital world. And this COVID pandemic is going to go on for months and into next year. That is for sure. So Sam, if I come to you next, because one of the challenges we're hearing from teams, very experienced teams who know how to deliver, you've mentioned some of the ways you're mitigating and stratifying the risk that is associated with sick people with chronic lung disease who need to partake in a pulmonary rehabilitation program. So that typically 6 to 8 weeks, twice a week, if that's right, the model that exists. So can you just talk us through how you're doing it, kind of like from a step-by-step basis? That would be really helpful.
Yeah, I mean, I think our service has moved away from that traditional sort of pulmonary rehab twice a week, you go to circuits for 6 to 8 weeks, and we've come away from that just very much based on sort of what patients want and talking to what they want, you know, talking to them about what they want. So we offer this very much a menu-based approach. I think we need to enforce the patients actually there's nothing more harmful to them and their respiratory condition than sitting still, and that's what we need to get away from. And I think we also need to remember that as healthcare professionals, we need to demedicalise these patients. They spend most of their life in the community functioning, so we need to very much get the way that they're sick people. You know, they are patients with chronic conditions, but they have to manage those chronic conditions, so we have to get them moving. At the minute, we are offering, say, like a very much a menu-based approach. We're doing home exercise sessions with or without sort of support from the healthcare professional, again, depending on what the patient needs. We're doing some virtual group sessions on Attend Anywhere, because that's one thing that we were very conscious about with if we moved everything digital and virtual, we didn't want them to miss out on that social support, and that peer support for each other is so key. So we are having small online groups. We've got an online exercise program that we're using for some patients, and we're looking at outdoor venues, so we're going to be starting up some walks and some bike rides and things as we can hopefully do a little bit more. You're on mute.
A menu-based approach. I love that. I mean, that is just like, if that's not patient choice for exercise, I don't know what is.
Because patients aren't the same, and we can't shoehorn them into this going to circuits twice a week, because that's not what they want. So normally we take people into gyms, we take them bowling, we'll go bike riding, we'll take them swimming. So you can't do some of those things now, but we still want to have that menu approach, because one size doesn't fit all, so we need to be flexible in what we offer to our patients to get the most out of rehab.
Elaine, do you want to come in there?
Sorry, I totally agree with Sam and her approach, because that is exactly how my kind of own mantra that I've thought for many years, and this is why I left the NHS, that we're trying to shoehorn every patient into this model of twice a week exercising at 60 to 80% VO2 max. Now in real life, with people without lung conditions, we all know that not everybody can go to the gym. We all join a gym, and then the compliance with the gymnasium is really poor. Now, some people much prefer to keep fit and healthy by, for example, walking, or maybe playing hockey or swimming, or just walking the dog, etc. Why on earth are we just keeping these patients where the only option is that they go to pulmonary rehab, where the only mode of exercise is twice weekly resistance and cardiovascular exercise? And I absolutely think people like Sam is absolutely on the money. This is what we should be doing, is saying what is going to reduce sedentary behaviour. And perhaps this is the time now with COVID to start thinking about, could we maybe online delivery will force us to deliver a lower intensity mode of exercise, but it might be something that the patients adhere to much better, so we get much better compliance, a lot less dropout, and better out. We might not get huge differences in 6-minute walks immediately, but we might get a much better, more broader impact for these patients.
Sam, do you want to come in there?
Yeah, just to echo what Elaine's sort of saying, really, I think, you know, when patients complete rehab, there's really good evidence that we increase their walking distance, and we know that, you know, rehab increases walking distance. But when you sort of translate that into actually a patient's more active in their day-to-day life, then the two don't necessarily translate. And what we need to do is make patients be more active in their general day-to-day life. Very few patients come to our programme and say at the end of rehab they'd like to walk 25 more more meters, but what they actually want to do is play with the grandkids more, be more independent with their activities of daily living and feel less breathless when they're doing things. So I think rehab really needs to reflect that.
Paul, do you want to come in? No.
Yeah, I think you hit the nail on the head, because as Sam was just speaking, that national thing which talks about what matters to you. We had that last week, what matters to the patients. So at the breathlessness clinic at the hospice, one of the things that we do exercises, we do this exercise. And what that exercise is related to, helping patients so they can comb their hair with less breathlessness. One of the exercises we do where we grab something and we twist it.
Mm-hmm.
And what that is related to, can a patient now open a jar or a lid because their wrists are stronger? So we've literally gone from the patient getting out of bed for all the way through their day. What is functionally, what can they do easier? As soon as the patient starts to begin to do something easier, they're motivated to do more. And I just thinking to myself, one final thing, that if that menu that Sam talked about, if we think about Marmite, right? Marmite, I hate it. And one form of exercise that we offer in pulmonary rehabilitation, patient might say no to the whole lot. But if you have a wide menu, then the patient says, yeah, okay, I want to try Tai Chi. I might want to try aqua-based aerobics. I might try cycling, something else. Then it goes down to not what matters to us as outcomes. We brought it back. What matters to that patient? Isn't that the key?
So I think that's fine, but I'm just with my commissioning head on in my manager head. We commission services here, and in this situation, there's pulmonary rehab services that are commissioned, and the challenge is restarting pulmonary rehab in a virtual world. So I think that there's something within us to have the gift of flexibility, and I get that, but really the commission service, what's delivered, where the evidence base lies, is within pulmonary rehab in that model. So Sam, you touched on the virtual PR groups that you're running specifically. So I think it'd be really helpful for the listeners who maybe don't have the flexibility just yet, even though hold that thought, everyone, because I'll come back to that. How is it possible to be run now? I'm hearing on the grapevine, when I was doing a bit of research this podcast, like people are running sessions like with 4 people rather than the full complement, that they're checking people in terms of like 10 minutes before the class starts, are you okay, doing a screening tool. These are people that have already had like a telephone screening assessment. And then the risk. So imagine you've got a patient that you've screened them into a pulmonary rehab model, and they're safe to do a group exercise. They may or they may not have a SATS monitor in the house, because that's not feasible for everyone. And how do you actually deliver that program, that class?
So we use the Attend Anywhere platform, because when we started exploring this, we got told that we couldn't use Zoom because of sort of security issues. So we're on the Attend Anywhere. So we've had sort of 1 clinician and 6 patients on that as sort of a maximum. We did start off with quite small numbers, just so the team got used to it as well as the patients. When the patients log in to Attend Anywhere, you can have prompts. So we have some sort of exercise safety prompts. So just, are you well today? The standard things that we would ask them before they came and exercised in a group. So they have all that to prompt them. And then when they all sort of log in, we just check that everybody is sort of, there's been no change in anything since we saw them at the last session. And then it's sort of, like Elaine was sort of saying before, it's some basic, exercise safety advice that we're giving people, continuously while they're exercising, but we get the added sort of bonuses that we can see what the patients are doing, so we can modify technique, we can change intensity, change exercises if we need to as we go along, but then the patients have got the ability to speak to each other as well, so they're getting that bit of peer support, and every time we do a group, it's the same group of patients that log in. So though normally we'd have a couple of members of staff and sort of 12 plus patients in a group, we're still getting the same numbers through because we're having sort of a 1:6 ratio now. So 2 separate members of staff are doing 2 separate groups. And then we can give patients sort of more one-to-one education advice if they need that, and we can book them in at a separate session to go through what their individual, you know, sort of needs are about their sort of disease.
So you have a patient who is attending a class and they have an iPhone or an iPad or a laptop or a computer or something. How do they physically manage to do their activity when they're just looking at a screen and you can see them? Is that easy? To me, that sounds, knowing the patient population we're talking about, is a challenge.
They've been managing really well. I think the hardest thing has been getting everybody to log in through the system, just because it's sort of usually a slightly older population that we're dealing with, might not be as tech savvy, and that did take, you know, it did take us a little bit of time coaching patients how to log in, but once they've got into it, it's working well. The exercise is working well. We obviously advise them to make this, you know, the space that they're exercising in safe, and put whatever device they're using, whether it's a laptop or iPhone, iPad, you know, at a good sort of level, so they're not having to sort of like bend down and keep looking at screens and turning and things.
Okay, so they're doing the class and you finish the class, then what happens next? Do you do your kind of post-assessment stuff, or?
Do you mean after each session, do you mean? At the end
like after each session, normally have your cup of tea and biscuits, don't you, with a pulmonary rehab? Do you have that virtual, does that still happen normally?
We give them that time just to sort of chat and sort of talk to each other. We ask them how they've been getting on in the week, so they do have that sort of social support. They have to provide their own tea, unfortunately. But so get that.
So you've done the class, you've had your little social bit, and then do they come for a set number of weeks still?
Yeah, at the minute we've been doing it for sort of 5 weeks, and then the idea is that they should be sort of pretty independent with their exercises. Obviously we can modify and progress them every week, and then after that they'll have sort of weekly contacts from the team, whether that's a phone call or a visit, depending on how they sort of, you know, how they want to keep contact with us. We've sort of dropped the frequency to 5 weeks just because we've struggled with waiting times, really, because obviously we did hold all assessments for quite a period of time, so during that time we were still accepting new referrals, so we do have, you know, a waiting list that probably feels uncomfortable to us as a service. And the other thing we're trying to do as well is sort of contact the shielding patients as a priority to offer them some sort of rehab and support, because obviously they're the ones that are most at risk of deconditioning.
And do you have specific like risk assessment tools and things you use specifically for the virtual exercise and classes?
No, we haven't got anything sort of set in stone as yet. I mean, we're very lucky in our team. We've got some really experienced sort of staff, whether that's physios or exercise physiologists. They run the class, so obviously patients still have their very detailed pre-assessment, so that's done on the phone, and then we will do some sort of exercise test with them beforehand. It might not be an incremental or, you know, a shuttle walk or anything like that, but we want to see how, you know, they respond to exercise, so we go out and do that. We're very fortunate in our team because we are a fully integrated respiratory service, so we share all the records with our respiratory team, and we've got sharing rights with primary care, so we, you know, we've got a really detailed knowledge and understanding of our patients.
Yeah, I think that's one of the keys. So worst case scenario, which is the manager heading, is you have a patient that has a panic attack, or they have, you know, a breathlessness attack, or they hyperventilate, or they collapse, or they have a heart attack. How would you manage that? How would you calm the manager in me down?
Obviously we'd like, you know, if the patient's got a relative or somebody with them while they're exercising, that's great. So, you know, if something does happen, then you've got someone there that's responding. Most of these patients that are coming through, you know, they are well known to us. You know, some of them might, you know, have done pulmonary rehab before, some of them haven't, some of them are brand new. I think my manager probably doesn't like me because I probably do make a cringe about some of these things, but, you know, if you're taking all those basics, exercise precautions. You're giving the patients, exercise advice. If, anything untoward does happen, you get them to stop, sit down. You've got someone in the house, or we, if they did collapse on their own, we could call, an ambulance, because you can see what's happening. I've been running pulmonary rehab groups for, 10 years or so now, and that has never happened in any of our sessions.
And Elaine, if I bring you in here, you've got some interesting thoughts about that. You've been running pulmonary rehab for a long time, and you've got a lot of experience in this. What's your thoughts on that, the risk adverse nature of sometimes us therapists?
So I think I know that where pulmonary rehab has been run in hospitals, I've run it for most of my career out in the community, in church halls, a working man's club, village halls, all sorts of weird and wonderful places. And actually, we do sort of we're quite used, when we have run pulmonary rehab in the community, we're very, very used to that sort of risk out there. And I think people who deliver pulmonary rehab in a hospital, it might frighten them a little bit more than it does perhaps myself, who's used to just dialing 999 if somebody collapses, because that's all you've literally got in a community hall. But just like Sam said, in 20 years of running pulmonary rehab, I remember distinctly only 3 patients that I ever had to call an ambulance to. And I would say that they had keeled over, not directly linked to their pulmonary rehab. So I think the risk is low. And like Paul said, the risk of doing nothing is more than the risk of doing something.
Lovely. And Paul, I'm going to come into you, because again, pre-chat, you talked about this, but you also talked about how, you have good experience of patients actually doing a lot more than, what we think they do. So they're already exercising in a manner, they just need maybe direction or...
Yeah. Because sometimes when you're speaking to these patients and you ask them the question, what have you been doing? So the one that I always remember the best, this patient says to me, he was walking up hills and he stops when he gets too breathless and then he starts off again. And I'm trying not to show my shock on his face for what he's doing. So he's doing all this without any guidance, any input, any support. So what that was telling me, that was a group of patients, I come across it more and more and more, they were exercising independently without any problems or without any proper safety issues that we would actually say to them. So then when we actually come across them, we would probably modify down their intensity, or don't do the hills, maybe do the majority on the flat to begin with and only do it for this time period. They were doing far in excess of what we would have recommended them to do to begin with, without any problems. Now, with regards to part about health and safety, I was thinking to myself about sometimes we have these super fit athletes who collapse on the field, no underlying comorbidities, nothing whatsoever, super fit athletes. So you deal with these patients with the same way. So literally what you'd actually do, you deal with these patients in the same way. Obviously, as Sam was saying, we've got their full medical history, but it has to come down to this, because time and time again, by the time patients get to pulmonary rehabilitation, they're so severely deconditioned that is now causing so many problems. So I think the good thing about virtual and other stuff, the quicker we get them started, the better it is for the patients, for the commissioners that you actually talked about, because the commissioners, the less the patients go into hospital, because as the audit was brought out by the Royal College of Physicians in 2018, it's 4.8 days if a patient completes pulmonary rehabilitation. I think it was 9.6 days in the hospital if they didn't complete it. So that's what these commissioners want. They want to keep these patients out of hospital or reduce their hospital bed stay time, and pulmonary rehabilitation can half the time they stay in the hospital bed if they complete it. It's a win for everyone.
So I think the message I'm getting, and to bring in some of the national thoughts as well that I've been given for the reason for doing this podcast, is around some of the individual stuff, you know, services are doing, some of the existing rehabilitation that was happening pre-COVID, they're doing. They know these patients, they're just doing it in a different manner. The urgency now is, I think they've been waiting for, there's some amazing work going on behind the scenes with like Sally Singh's team, and you mentioned Julia Bott in terms of this Pan London work going on. I think people have been waiting for the national guidance and saying this is what you should be doing. And the feeling that we're getting through, the messages we're getting through to the ACPRC is that's not coming. And now we've got hundreds of patients now waiting, hundreds of patients that are at risk, hundreds of patients that want advice about pulmonary rehab and how they do it and how we do it as the service leads. So from what you're saying is there's a variety of ways you can do this. You can modify your service within your existing agreements, but you might just need to change your approach to it. Is that kind of what we're saying? Elaine, you've given some great examples already of how you've done that from the start of the pandemic, but have you got anything to add on that of how you know, what this patient population needs and how we can meet the needs?
Yeah, Rachel, you alluded to the evidence base and the evidence base for pulmonary rehab, and no one believes more than in pulmonary rehab than I do. No one's fought harder than I have for pulmonary rehab. However, there is evidence for sedentary behaviour, for physical activity. We know that patients, you know, it lowers the risk of admission, it increases survival. We know about loneliness, we know about reducing their frailty score. All these are risk factors for an earlier death, for increased exacerbation frequency and increased hospital admission frequency. So even if people actually are providing more of a physical activity driven program online that might be a little bit safer to implement, a little bit easier, you're still commissioning something that's very, very evidence-based. And you know what, even if somebody's just providing support groups where patients, you're reducing patients' loneliness and just increasing that connectivity. Social connectivity is so highly evidenced that actually you're still commissioning something evidence. So I think just because we're not offering a traditional pulmonary rehab program with 3 times a week exercise online doesn't mean to say that we're not doing something that is effective, has impact for the patient, and it's still evidence-based. And I think now is the time to really rethink the whole pulmonary rehab model.
Paul?
Yeah, I was going to say that also as well, if people are scared of adapting things, regards when we've got these long waiting lists building up, all the leads, they'll be familiar with the NHS long-term plan. And there's a paragraph in there, I don't want to misquote it, but basically it's saying about different forms of pulmonary rehabilitation. So all these pulmonary rehabilitation leads, they're scared of doing things a different way. But the NHS long-term plan, specifically when it refers to pulmonary rehabilitation, Elaine might know the actual phrase. I looked at it and I thought, wow, this is incredible. So I don't want to misquote it, I don't know the exact phrase, but it's not giving people license to do anything under the sun, but it's saying, well, try different methods.
Yeah, and I think because there's such differences in services and how they're delivered and what patients want within the demographics, it's like there's digital poverty that exists. For example, digital poverty has been a real barrier for some people in deprived area doing anything virtually. So then the CCGs have had to invest in iPads and other brands of tablets to allow that visual access. Sam, can I bring you in for comments on that, please?
Yeah, just to follow on from what Paul was saying, even the Cochrane Library did a big review on pulmonary rehab and the evidence base behind it, and they stated that we don't need any more evidence. We know pulmonary rehab works, but what we need to do is find the best way to deliver that, which very much fits in with the long-term plan. And people shouldn't be scared to do things a little bit differently, because if we do things and deliver services in the same way that we've always done, we're always going to get the same output at the end. And the output is actually very few patients go through traditional pulmonary rehab services for whatever reason, because they're not referred, it doesn't suit with them. So as a PR group, we have to do things differently, and this is a golden opportunity to look at the services we're delivering. You don't often get this delivered to you on a plate where you can start again, and this is a perfect opportunity for colleagues to be able to do this. And I would encourage anyone just to do things differently.
Yeah, and it's interesting as the non-PR person here, because obviously I have managed PR services and done it as a junior. But the patients that done pulmonary rehab, they just bloody loved it. Like their little faces at the end and what they achieved. And, we have the pulmonary rehab friends, don't we, that come back as volunteers and they never want to leave. And but then you're right, that's a minority of people who actually get to that first stage. So what happens to all the other people? I think that's really interesting, and how we can redesign. That's a whole point of NHS innovation, isn't it? Just seeking out, like you said, Paul, what the patient wants. So I'm going to start wrapping it up, and then I'm going to come to everyone for comments. So we'll have to put this podcast on about virtual pulmonary rehabilitation and how services are struggling to implement it. So within each of the individual services, maybe go back and think about what are we trying to implement, and are the barriers, some of the barriers that would exist normally in implementing the traditional pulmonary rehab model. We need to identify what the patients want, like everyone said. So what do your patients actually want to access? Then is there a different way to deliver it that might reduce your barriers? And there might be different ways, different things you need to look at within that commission package. Like Paul says, and this is a way that I would certainly approach commissioners or managers about it. Some commissioners might not have a Scooby-Doo about what they're actually paying for anyway. Some might be very outcome based and they want to know how many numbers have done it. You might have performance targets to hit. So we need to be careful of this so we don't lose kind of money in commissioning. But actually, to have conversations, 9 times out of 10 in my experience, if you have conversations with people and you say the end result, like Paul says, is these patients will not get seen in any capacity, and that's more detrimental to the whole health economy than actually doing things different because we have the opportunity. And then it's about the safety aspect. So whatever safety implementation you make, it has to be realistic so people can do it and they can reproduce it. But it also has to have meaning as well. And like Elaine says, just use your common sense here. People are going to be active. They're going to do things. We need to just mitigate the risk about implementing basic common sense principles, but in a patient group that is vulnerable, aren't they, for falls, for breathlessness, for all the other things that we need to be aware of. So, Paul, if I come to you first, do you have any comments, any final comments or anything that you'd like to bring up that we haven't covered?
My first comment is I'm going to eat some more cake later on. And I think with many things, when it comes down to the commissioning of these services, is that sometimes it's a matter of asking the commissioners for more money. Because often, if we were to think about pulmonary rehabilitation as a drug, and if this drug could cut hospital bed stays from 9.6 days to 4.8, and you went to a commissioner and says, well, can we have this money? And the commissioner says to you, well, what would be the impact? The impact would be this, reducing hospital bed days from 9.6 down to 4.8. Would the commissioners then invest in the actual drug? But not only the commissioners, in Scotland and Wales, the health boards as well. So I think sometimes you have to have the courage to ask for the actual money, but explain to the commissioners why you actually need the money. And sometimes, through my thinking, people who lead pulmonary rehabilitation, sometimes they might need ring-fence protected time to get to communicate with these commissioners and all these other people who are funding these. Then the patients can get the benefits, because in the end, if we class pulmonary rehabilitation as a drug that has a massive impact, then the NHS is invested a lot of money in a lot of drugs. We just need more money for the drug called pulmonary rehabilitation.
Elaine, can I come to you next?
Pulmonary rehab, traditional pulmonary rehab is clearly life-changing, regardless of the research. It changes patients' lives. It's amazing. However, a tiny proportion of eligible patients actually complete a traditional pulmonary rehab program. Anne Holland brought out a paper a couple of years ago. I think the title was something like, has pulmonary rehab passed its peak, or something like that, and she argued that it's fantastic, but because of the poor completion rate, what about all the patients who don't access pulmonary rehab? So with COVID, this terrible thing that's happened, I think, is a wonderful opportunity to absolutely revisit our existing model. And I upset people by sometimes being quite contentious in questioning sort of traditional model, but that traditional model is over 20 years old. It's the same model that I was doing 20 years ago today. And my feeling is now the time to really question that, look at what we're doing. Is exercise, it's undisputable the impact of exercise on the patient's outcomes, but actually it's not the only part of pulmonary rehab, and now's the time to look at the other components and to bring prominence to the other components. And just a little thought that I thought about a lot when I left the NHS: not everything that we do for patients is actually clinical, and sometimes just showing them compassion is actually quite scientific and has a really big impact on their outcome. That's it.
Thank you. And Sam?
I think, I mean, how to follow what Paul and Elaine said, they sort of said it all really, but I think, you know, this is a golden opportunity, I think, and we need to take what's happened with the pandemic and use that to how we can get to those 85% of patients that, you know, don't take up that offer of PR. We need to do things differently. We have to really, you know, prove and show our effectiveness on a wider scale. We have to diversify, make ourselves available to, you know, to more patients so that they can get the benefits, because it's life-changing.
Excellent. And on that note, there's obviously a bit of controversial opinion there that I wasn't expecting, to be honest, as a podcast host. So if there is anyone out there that has a completely different way of thinking, or maybe doesn't agree with anything that's said, then I'm pretty sure the ACPRC are, look, this is why they've kind of invested time in doing this, because it's an easy way to get people's messages out. And if anyone wants to come on and have a follow-on, like a pulmonary virtual PR part 2 session, if you've got any questions, please get in touch. And I'm sure the panel members will rejoin me with anyone else that wants to join in too. So thanks very much. And thanks everyone.
Very much appreciated.